Hello, hello. 1, 2, 3. Hello. কিছুক্ষণের মধ্যেই শুরু হবে ফার্স্ট রাউন্ড, এটা রাফেল ড্র, আকর্ষণীয় অনুষ্ঠান। এখনো লোকজন বেশ কিছু কম, তো পসিবিলিটি অনেক বেশি। হ্যাঁ, আচ্ছা আচ্ছা। এই তুমি আমার কাছে আসো। ইয়েস, ইউ মাই নেফ্রোলজি, কাম হিয়ার। আমাদের এখন ডাক্তারদের জন্য এটা এরকমই থাকুক, ভাগ্যে এরকম যে ফেলা হয়েছে, এখানে মামুন স্যার নিজের হাতে ফেলছে। তো এখন শুরু হচ্ছে আমাদের র্যাফেল ড্র ফর ডক্টরস। তুমি এটা ফেলে দাও ভিতরে। রাইট, ভিতরে পড়ে গেছে, আমি নেড়ে দিচ্ছি। পিক আপ ওয়ান। চোখ বন্ধ করে এটা তুলো। দিস ইজ দ্য ফিফথ প্রাইজ, 198. ওয়েলকাম। তুমি এর মধ্যে ফেলে দিছো তোমার কাছে? আচ্ছা, 198 কে? ঠিক আছে। What? Yes, stand up. It's 6. What intuition? 160. So Midhun got the 160. Okay. Second prize, fourth prize. So for third prize, একটু অনেক বাড়ি চাকরি দেওয়া যাবে না, নাম্বার দেখা যাচ্ছে তো মুশকিল। ওকে, পিক আপ। একটু উল্টা পাল্টা আর কি। So this is the third prize. Middle number 0. Middle number 0. Last number 6. First number, what is the expectation? Who? To who? Please come. Now the second one. ওদিক তাকান যাবে না, হ্যাঁ। Yes. First number 1, second number 8. What is the expectation? Last number? No. No. It's a duck. 2. 1, 8, 2. This is very good. এবার আমি তুলি ফার্স্ট প্রাইজ। না দেখে তুলে দেখি কোনটা আসে, ওরটা আসে কিনা, অনেকক্ষণ কষ্ট করলো। লাস্ট নাম্বার 3, second number, middle number 9. What is the expectation? First number 1. Who? Yes, it's 193. The first prize. Please আপনার নামটা বলেন। 193 goes to Enamul Haq. First prize. Okay, that's the end of the lucky draw for the doctors. যারা পায় নাই, ডিসহার্টেন্ড হওয়ার কোনো উপায় নাই, নেক্সট টাইম।
আমাদের এই অনুষ্ঠান পরিচালনা করলেন আমাদের সম্মানিত ডাইরেক্টর গণস্বাস্থ্য ডায়ালিসিস সেন্টার ব্রিগেডিয়ার জেনারেল মহসিন আহমেদ। আমরা সকলে তার জন্য একটা করতালি দিতে পারি।
ঝরার বিনিময়ে সেই পাখিটি মুক্তি পেল, স্বাধীনতা পেল বন্দিশালা থেকে। আর এই পাখিটি হচ্ছে 1971 সালের আমাদের বাংলাদেশের একটি প্রতীকী অর্থ। কেননা পাকিস্তানি বাহিনীর নৃশংসতার কথা আমাদের কারো কাছে অজানা নয়। পাকিস্তানি বাহিনী সাথে যুদ্ধ করে 30 লক্ষ মানুষের রক্তের বিনিময়ে পেয়েছে আমাদের এই স্বাধীনতা। আমাদের এই স্বাধীনতা পেয়েছি বিজয়ের এই মাসে 1971 সালের 16 ডিসেম্বরে। আমাদের কাছে বিজয়ের তাৎপর্য অনেক, কেননা আমরা এই বিজয়ের মাসে স্বাধীনতা অর্জনের মাধ্যমেই জানতে পেরেছি যে কিভাবে স্বাধীন দেশে শ্বাস নেওয়ার অধিকার রাখা যায়। তাই তো সুকান্ত ভট্টাচার্যের ভাষায় বলতে হয়, সাবাস বাংলাদেশ, এ পৃথিবী অবাক তাকিয়ে রয়, জ্বলে পুড়ে মরে ছারখার, তবু মাথা নোয়াবার নয়।
বিজয়ের এই মাসে মৃদু বাতাস আর শিশির ভেজা শীতের আমেজের এই সন্ধ্যায় আপনাদের সবাইকে জানাচ্ছি আন্তরিক শুভেচ্ছা এবং অভিনন্দন। আসসালামু আলাইকুম। আজকের এই অনুষ্ঠানে আপনাদের সাথে আছি আমি ডক্টর ফাহমিদা সুলতানা রিমি এবং
আমি ডাক্তার হাসনা হেনা মৌ।
গণস্বাস্থ্য কেন্দ্রের এই মিলনায়তনে আমরা সকলে আজ একত্রিত হয়েছি জিকে নেফ্রোলজি কনফারেন্স 2022-তে। Ladies and gentlemen, good evening. We cordially welcome all of you in the third Nephrology Conference organized by Gonoshasthaya Kendra. Our Nephrology Conference has been designed to explore the scientific and clinical aspects of kidney disease. To start with, we now have the plenary session. To chair this session, we have Professor Dr. Ehtashamul Haq, Dr. Nurul Islam, Dr. Firdaus Kamal Bhuiya, and as moderator, Dr. Maksuda Begum Moni.
And the speaker of this session, we are extremely lucky and honored to address Dr. Ehsanul Karim. This session's topic is Management of Refractory Nephrotic Syndrome in Diabetic Mellitus.
Ladies and gentlemen, there is some corrections. In our first session, due to the road blockade, our chairperson could not attend in time. Our chairperson of the first session is Professor Brigadier General Mamun Mustafi sir and Associate Professor Dr. Yusha F. Ansari. And the moderator, Maksuda Begum Moni. Please come to the stage.
Assalamu alaikum and very good evening everyone. My honorable chairperson, respected colleague and senior and junior colleague, I welcome you to today's first session. And today we have two chairperson. We all know our very loving and very respected our Professor Brigadier Mamun Mustafi sir, and working as the departmental head of Gonoshasthaya Medical College and Hospital. And our second chairperson, our Dr. Yusha F. Ansari sir, he is working as associate professor at Uttara Adhunik Medical College and Hospital. And our today we have three speakers. And now I request our chairperson to start the session. Our first speaker, Dr. A.N.M. Ehsanul Karim sir, working as associate professor, Shohid Mansur Ali Medical College and Hospital. I request our first speaker to come on dais to deliver his speech. Sorry, there is a correction. Shohid Ziaur Rahman Medical College our first speaker, sir, is working as associate professor. Thank you.
স্যার ঠিক ভিউ দেন স্যার আপনি বলেন কিছু আগে কিছু বলেন বিসমিল্লাহির রহমানির রহিম আসসালামু আলাইকুম ভেরি গুড আফটারনুন আমি প্রথমেই ধন্যবাদ জানাচ্ছি আয়োজকদের আমাকে এই সেশনে কিছু বলার জন্যে কিছু শেয়ার করার জন্যে আমি প্রথমেই জানাচ্ছি যে এই বিজয়ের মাসে এই স্বাধীনতা মুক্তিযুদ্ধে শহীদ দানকারী সকলকে এবং আমি সর্বপ্রথম আমি শ্রদ্ধা জানাই আমাদের জাতির জনক বঙ্গবন্ধু শেখ মুজিবুর রহমানকে এবং মুক্তিযুদ্ধের শহীদ স্মৃতি আত্মদানকারী সকলের প্রতি আই এম স্টার্টিং মাই সেশন My topic is management of refractory nephrotic syndrome in diabetes mellitus. Diabetes is the leading cause of end-stage renal disease in developed countries. Besides, in developing countries, diabetic kidney disease is also increasing. Additionally, severely increased albuminuria or massive proteinuria and renal insufficiency are frequent accompaniment of diabetic nephropathy. However, a second disease superimposed on diabetic nephropathy of concern, especially if the proteinuria is massive or renal failure is deemed to be acute onset. Now, terminology. Diabetic nephropathy historically defined as the clinical presence of albuminuria accompanied by retinopathy in presence with type 1 diabetes. And the presence of albuminuria was considered to be an early signs of classical diabetic glomerulopathy, which is characterized pathologically by glomerular basement membrane thickening, endothelial damage, messenger expansion, and nodules and podocyte loss. But in terms of diabetic kidney disease, it is a clinical diagnosis based upon the presence of albuminuria, decreased GFR, eGFR, estimated GFR, or both in patients with diabetes. But it is not intended to indicate a specific kidney disease phenotype in patients with diabetes. Rather, various forms of kidney disease attributable to diabetes, including non-classical glomerular lesions and also the tubulointerstitial disease. These are the pathology of diabetic glomerulopathy, that is a diffuse capillary basement membrane thickening and also podocyte effacement and also the mesangial expansion. And histologically, that is development of the nodules and loss of architecture of the glomerulus. What are the risk factors leads to the development of the nephropathy? Uncontrolled diabetes mellitus for long-standing, high HbA1c, high systolic blood pressure, albuminuria grade, severe the albuminuria and chance of progression of the renal disease is more. Decreased baseline GFR, duration of the diabetes, and other microvascular complications like retinopathy, peripheral and autonomic neuropathy. Family history also important for development of the diabetic nephropathy. We know there are metabolic factors and hemodynamic factors. All are the causes activation of the intracellular signaling pathway, oxidative stress, and other pathways, including causing inflammation, fibrosis, and ultimately development of the diabetic kidney disease. These are the conceptual model of the natural history. Hyperglycemia and cellular injury starts with microalbuminuria and macroalbuminuria. GFR initially normal, low, and ultimately GFR is decreased. And hypertension, as we know, the severity of the albuminuria associated with severity of the hypertension. Massive albuminuria associated with severe hypertension and also progresses with cardiovascular complications. This showing that is albuminuria. Excess glomerular albumin leak. What is the fate of the albumin? This albumin ultimately reabsorbed in the renal tubules, and that is tubular leakage, tubular transcytosis, and also the uptake of filtered albumin. This albumin is accumulation causing inflammation and ultimately the tubulointerstitial disease. And then tubular reabsorption of the albumin also hampered, and so the albuminuria in later stage of the diabetic kidney disease, albuminuria is more and more. This slide shows that is glomerular damage and tubular damage leads to the microalbuminuria, and initial phase of the hyperglycemia leads to the increased glucose load to the proximal convoluted tubule and leads to the descending loop of the loop of Henle. And this there is increased absorption of the glucose and sodium and chloride. That is sodium glucose cotransport 2 that is upregulated. This upregulation is causing the changes and ultimately leads to more sodium and glucose absorption in the proximal tubule and decreased delivery of sodium to the distal tubules, and ultimately macula densa is activated, so afferent arteriole is vasodilated and efferent arteriole is vasoconstricted, and development of the intraglomerular hypertension. And this also leads to development of the more progression of diabetic kidney disease and leads to marked albuminuria. Now, nephrotic syndrome. As we know, the nephrotic syndrome is defined by the presence of heavy proteinuria, hyperalbuminuria, peripheral edema, hyperlipidemia, and thrombotic disease. And the term nephrotic syndrome is generally used for an immune-related kidney disease with poor clinical outcome, especially resistant to treatment with steroid or immunosuppressive for 6 months. So the refractory nephrotic syndrome specially termed for immune-related kidney disease, not for diabetes mellitus. But when the nephrotic syndrome in diabetic kidney disease or diabetic nephropathy is intractable, sometimes it is termed as a refractory nephrotic syndrome in diabetes mellitus. 30% of the adult patients with nephrotic syndrome having systemic disease, they like diabetes, amyloidosis, SLE, and remaining are due to primary renal disease, that is minimal change disease, FSGS, and membranous nephropathy. Nephrotic syndrome also can develop in other immune-related disease, that is immunoglobulin A nephropathy, post-infection, and membranoproliferative glomerulonephritis. Sometimes heavy proteinuria occur in the absence of hypoalbuminemia or edema. Management type of this nephrotic range proteinuria or heavy albuminuria is same that of nephrotic syndrome. This may occur in diabetes mellitus or any other primary renal disease. Nowadays, albumin excretion is the prime importance for development for classification of the severity of the diabetic renal disease. When ACL level is 30 to 300, it is called moderately increased albuminuria. When more than 300, it is called severely increased albuminuria. As the albuminuria is progress, that is more time progress, the GFR is decreased and nephron mass is also reduced. this slide shows the KDIGO guideline according to the albuminuria and CKD staging. So, today's topic is about the management of severe increased albuminuria in diabetes mellitus. General measures applicable to all patients with diabetes mellitus, like all of the diabetic patients, although some specific considerations like lifestyle modifications, healthy diet, physical activity, smoking cessations, and weight management. Regular risk factor assessment every 3 to 6 months. Glycemic control, first line if GFR more than 30, this is metformin, and second line if GFR more than 20, that is sodium glucose cotransport 2 inhibitor. Regarding management of the glycemic control, it is recommended that the HbA1c is 7% or less in all patients with type 1 or type 2 diabetes. All patients with diabetic nephropathy have cardiovascular risk factor. So lipid lowering drugs with atorvastatin or simvastatin, fluvastatin should be started. If the patient having renal failure, these drugs are safely started because they have no need to dose reduction. Dose reduction in case of GFR. In case of hypertension management, diabetes with CKD, blood pressure target should be 125 to 130 and less than 80. Regarding management of the hypertension in diabetes with proteinuria, AC inhibitor or ARB should be started. If this could not control the diabetes, then dihydropyridine calcium channel blocker would be started. Patients with severely increased albuminuria or massive albuminuria, non-dihydropyridine calcium channel blocker or diuretics may be added, but never combined should AC inhibitor or ARB with combined, or combination of one of the drugs with renin inhibitor should be avoided. There are several groups of AC inhibitor and ARB, all are the similar efficacy, should be used with cautions with special considerations. Diabetes with diabetic nephropathy, intractable edema is a factor to manage it. There is a study published in 2015, use of dapagliflozin to reduce the edema in patients of hospitalized patient. This slide shows that patient was started with oral furosemide and injectable furosemide, but there is no improvement of diuresis. But on the day the SGLT2 inhibitor was started, then the diuresis was started, and after 11 days, that is weight loss with diuresis, and also that is urine output also increase. That is after started of SGLT2 inhibitors, and weight is reduced. Serum creatinine, baseline serum creatinine is also mildly increased but stable, and urine output is also increased and weight is also reduced. It can be used as a volume overload in a patient of diabetic nephrotic syndrome. Another study is published in 2019, same used as a renin-angiotensin system inhibitors. This causing urinary glucose excretion with urinary sodium excretion, decrease extracellular volume, and also body weight and blood pressure reduction. So these drugs may also use as a not only in glucose lowering, but also in volume reduction and weight reduction. Effect of SGLT inhibitor on kidney disease progression, there are meta-analysis of 13 trials of over 90,000 participants, namely as Credence, DAPA, CKD and IMPA kidney trials. All results is reduced rate of kidney disease progression regardless whether the patient had diabetes. So patient with severely increased albuminuria, absolute benefit of SGLT2 inhibitor therapy is greater among those with higher level of albuminuria despite similar risk factors. Now, mineralocorticoid receptor antagonist in albuminuric CKD. Activation of mineralocorticoid receptor is associated with cardiovascular or kidney disease, putatively by stimulating the inflammatory and fibrotic cascade. Steroidal MRA such as spironolactone was tried with, but they are associated with hyperkalemia. Non-steroidal mineralocorticoid receptor antagonist phenylalanine also reduce the albuminuria, has a similar effect on serum potassium. So these drugs can be used in diabetic CKD to reduce the progression. There are two large trials, Fidelio DKD and also Figaro DKD, and also that is also a pooled analysis of these two trials, fidelity pooled analysis. Both trials significantly indicate that they are non-significantly reduce the all-cause mortality. So we can use the phenylalanine in patient with massive albuminuria when the patient on angiotensin receptor blocker or inhibitor combined with SGLT2 inhibitor, despite the use of the two drugs, persistence of the albuminuria, then this phenylalanine can be used. Now, glucagon-like peptide 1 receptor antagonist showed the slow rate of decline in GFR and prevent the worsening of albuminuria. If the initial glucose lowering therapy is ineffective and patient is on SGLT2 inhibitor, GLP-1 agonist may be used to reduce the maintain the blood glucose level. So, KDIGO Executive Summary 2022 and American Diabetic Association combinedly preliminary reports suggested that diabetic kidney disease management with albuminuria especially combined with renin-angiotensin system inhibitors, metformin, sodium glucose coateoxide 2 inhibitors, glucagon-like peptides, and a non-steroidal mineralocorticoid receptor antagonist. Now the management of the edema in severely increased albuminuria in patient of diabetes. As usual, normal management of the other nephrotic patient, dietary sodium restriction, 2 grams per day, and diuretics can be used. First level is loop diuretics, furosemide and torsemide and bumetanide. If the loop diuretics is not works at all, if the patient is hypokalemic, spironolactone may be added. If the patient is normokalemia or hyperkalemia, maybe thiazide-like diuretics, metolazone, chlorthalidone, or indapamide, or thiazide-type diuretic, hydrochlorothiazide may be added to block the distal tubule and counteract the electrolyte imbalance and also improve the diuresis. These are the all diuretics used in edematous state of nephrotic syndrome. Patient with severe hypoalbuminemia, plasma albumin less than 2, albumin infusion sometimes advocated, but after addition of the albumin, sodium excretion through urinary sodium excretion should be monitored. If there is no recognizable increase of sodium excretion on urinary, then sodium albumin infusion should not be continue. A variety of factors can account for persistent sodium and water retention without typical use of the diuretics, with inadequate diuretic dose, decreased intestinal absorption of oral diuretics, decreased diuretic secretion in the tubular fluid, increased sodium reabsorption at the sites nephron other than the other diuretics, excessive sodium intake. These are all discussed earlier. Patient unresponsive to intravenous diuretics and sometimes albumin. What then we can do? We may use ultrafiltration, slow continuous ultrafiltration or continuous venovenous hemofiltration. Kidney replacement therapy is generally reserved for patients with substantial cardiorenal dysfunction who require concomitant dialysis or in patients controlled in clinical trials. This is an unusual situation associated with cardiac failure. Now, the progression or regression of albuminuria. Factors favoring the progression or albuminuria is better management of glycemic control, blood glucose, and other blood lipid profile management. In a study of 397 patients of type 2 diabetes mellitus, 20% have regressed to the normal level of albumin excretion and 19% experience progression to severely increased albuminuria. So, when a patient presents with severely increased albuminuria as a part nephrotic syndrome, so he or she may be regression with adequate control and adequate medications. Monitoring the severely increased albuminuria. Every 3 to 6 months we should monitor the volume status, blood pressure, eGFR, serum potassium, SbA1c, and elevation of the serum albumin, evaluation of the serum albumin or total protein excretion, usually random ACR. A referral to patients with diabetic kidney disease to a specialist nephrology, especially when advanced CKD, heavy albuminuria, resistant hypertension, evidence of an inflammatory kidney disease, that is hematuria or sterile pyuria, and difficult to manage complications, that is hyperkalemia or anemia. When we suspect a case of diabetic disease with a non-diabetic kidney disease, severely elevated albuminuria, red blood cell cast, dysmorphic RBC, presence of other systemic disease, and sudden rise of albuminuria, sudden development of nephrotic syndrome, or rapid decline of estimated GFR, we should suspect the case with a diabetic patient having a non-diabetic kidney disease, that is primary glomerular disease or other diseases. In 2013, there is a report with kidney biopsy with a diabetic patient. 61 biopsy patient, then 1/4 of them are diabetic patient. 1/3 of the diabetic patient have diabetic glomerulopathy, 1/3 having diabetic glomerulopathy plus non-diabetic kidney disease, and 1/3 having non-diabetic kidney disease alone. What are the non-diabetic kidney disease? Acute tubular necrosis, immune-related glomerular disease, hypertensive nephrosclerosis, and focus segmental glomerulosclerosis. Now, my experience share with Bogura Shohid Jawaharlal Medical College, renal biopsy finding of diabetic patients. We performed renal biopsy at Medical College Hospital. Total number of patients was 34. About 34 patients, 12 patients was reported as a case of diabetic glomerulosclerosis, that is 35%. 6 patients having non-diabetic kidney disease coexisting with diabetic glomerulosclerosis, that is 18%. Then are acute interstitial nephritis, messenger proliferative glomerulonephritis 1, C1q nephropathy, SLE, and PIGN. And 47% of the total biopsy patient having non-diabetic kidney disease. What are the differentials? They are all are the primary glomerular diseases. Now, a patient with diabetes with nephrotic syndrome, one of the 34 patients, Mrs. Nasrin Akhtar, 44 years age, diabetes for 4 years and hypertension for 2 years, recurrent leg and body swelling for 6 months. She was on hypoglycemic agent glimepiride and linagliptin, and antihypertensive olmesartan with hydrochlorothiazide and bisoprolol, and lipid lowering drugs. For her swelling, she is taking furosemide and spironolactone. On examination, she is mildly anemic and moderately edematous, blood pressure 170 and 90 with those antihypertensive, and on other systemic examination otherwise normal except ascites. Investigation findings means albumin 3 plus, RBC 6 to 8, granular and hyaline cast present, serum creatine 1.4, serum albumin 1.8, and serum total protein 4.2. 24 unit total protein is 10 gram per 24 hours. She is recently diagnosed a case of hypothyroidism. TSH was 14. Random blood sugar is 8. Ultrasound abdomen is moderate ascites with mild bilateral pleural effusion. Cardiac function reveals ECG is normal. And provisional diagnosis is diabetes, hypertension, hypothyroidism with nephrotic syndrome. We have facilities to retinopathy screen in every hospital. She had diabetic retinopathy with maculopathy was found in both eyes. Serology screening was done as patient is female. ANA, anti-DSDNA, C-ANCA, P-ANCA, C3, C4 all is normal, and viral markers are also normal. Renal biopsy was done in 26 January 2022. Diagnosis was membranous glomerulopathy stage 2. For confirmation of as a patient who is a diabetic, we performed the phospholipase A2 receptor antibody quantitative. It was also positive, 438. Reference value is more than 20. These are the renal biopsy reports. This is the membranous glomerulopathy stage 2. These are the phospholipase A2 receptor antibody. It was done from outside Bangladesh. She received ponticillin, cyclophosphamide-based regimen, and other supportive measures. After receiving therapy, phospholipase A2 receptor antibody was negative, less than 2, after 6 months. On follow-up visit, urine albumin 2 plus, serum albumin 3.7, normal renal function, UPCR is 2.8, and also oral thyroid replacement therapy with TSH is normal. So final diagnosis is diabetes mellitus with membranous nephropathy with hypothyroidism. So take-home message, diabetic nephropathy is a long-standing complication of diabetes mellitus. Severely increased albuminuria, proteinuria, even nephrotic range, increased risk of manifold progress to ESKD and cardiovascular complications. Early interventions with appropriate therapy may slow or even regression of the albuminuria. Presence of non-diabetic kidney is kept in mind in an unusual presentation in diabetes mellitus. Thank you. Thank you for patience. খুলে ফেলি না এটা নাকি আচ্ছা থাক কথা বলেন
Thank you, sir, for your nice and elaborative and informative presentation. Now our second topic on diabetic complement in diabetic kidney disease. Our second speaker, Dr. Tabassum Sabat Madam, working as Associate Professor, Department of Nephrology, Bardem. I request our second speaker to come on dais for her deliberation. Thank you.
আচ্ছা আমারটাই না আমার কিন্তু এটা এরকম চেঞ্জ হলো কেন ডিসপ্লেটা চেঞ্জ এরকম ছিল না আমাকে জাস্ট এটা করতে হবে ওকে ঠিক আছে কিন্তু এরকম ছিল না ঠিক আছে অসুবিধা নেই আসসালামু আলাইকুম আসছে না কিন্তু স্ক্রিনে Today is 30th December. Few hours more, we will welcome the 2023 So at this moment, I would like to wish you all a very prosperous new year ahead. Today my topic is complement in diabetic kidney disease. The classic and global vision of DKD has placed it as a non-inflammatory glomerular disease, directing its pathogenesis towards classical pathway of hemodynamic and metabolic alteration. However, the vision is limited by recent discoveries and advances in understanding of immune system. The complement activation plays a role in various organs in diabetes mellitus. However, in diabetic nephropathy, the role of complement activation is poorly understood. Yet, I will try to focus on this topic. I'm Dr. Tabassum Samad. I'm acting as Associate Professor in Department of Nephrology of Bardem General Hospital. And before starting my speech, I would like to disclose that I have no conflict of interest in relation to this presentation. The immune system has two components. The first is surveillance, which it identify any potential danger in the body and gives signal. And next, the part which acts as SWAT team, recognize the specific danger and exterminate it. Let's have a quick overview of complement system. The complement system is constituted by soluble and membrane-bound proteins that respond to alarm signals and through a proteolytic cascade generate a plethora of immune effectors. The main triggers that activates the complement system are the classical pathway where the C1 binds with the immunoglobulin M or G immune complex, that is the classical pathway. The spontaneous and continuous hydrolysis of C3, that is the alternative pathway, and binding of mannose binding lectin to the carbohydrate moiety of the bacteria, which is rich in mannose. This is a lectin pathway. While each pathway is unique in its activation, they all converge to C3b, the central amplification system, which ultimately leads to priming the membrane attack complex. And this causes tissue injury and other effectors. Those causes chemotaxis, activation of the antigen presenting cells, and others like C3a and C3b causes podocyte injury, C5a and C5b causes T cell activation, maturation of B cell, and also reduce the insulin sensitivity in the adipose tissue. Now the question comes, does the kidney produce complement? Traditionally, we know that these complements are produced in the liver, but kidney also produces this. A study done in kidney transplant recipients where the donor-derived C3 was around 10% of total circulating C3 in recipients during acute allograft rejections, whereas around 5% of the donor-derived C3 was found in total circulating C3 during a quiescent period. Therefore, the kidney contributes around 5% of systemic C3 and it can synthesize more during tubulitis. And various researchers also show that kidney is sufficient amount of, it's possible that it can produce a sufficient amount of components of the complements. Okay, now let's see how this complement activation mechanism occurs in diabetic kidney disease. In diabetic kidney disease, the main increased amount of immune complex that deposits in the kidney tissue, which occurs through classical pathway, and increased autoreactivity of the MBL, that is mannose binding lectin, which binds with the increased glycolylated protein and thus causes the lectin pathway activation, and the role of alternative pathway is yet not clear. Another is CD59, which inhibits the MSC, that is membrane attack complex, and these glycated proteins, this reduces or inhibits this inhibitory effect of CD59. Therefore, all the complement activation exaggerates and ultimately causes increased amount of reactive oxygen species, increased release of cytokine and growth factor, ultimately leading to kidney inflammation and increased fibrosis. Now, what are the evidences that there is complement activation in diabetic kidney disease? Baspi et al. They did an experiment on autopsied kidneys, total 151, and they compared the diabetic cases with and without diabetic nephropathy with normal diabetic controls, and they found that there is deposition of C4D is more in diabetic nephropathy cases. Now, to investigate which complement pathway leads to this deposition of C4D. So they stained MBL and C1q and found that there is 6% MBL in the diabetic cases, but there is no MBL in the non-diabetic controls, whereas C1q was more in the diabetic cases with nephropathies. To gather more evidences in favor of the classical pathway, the researchers stained the diabetic nephropathy kidneys and compared it with the living donors in terms of all components of the classical pathway, and found that the classical components of the classical pathway are more in the diabetic nephropathy cases. And to gather evidence regarding the lectin pathway, Ostegard et al. They studied the streptozocin-induced mice who developed type 1 diabetes and stained the kidney tissue and found there is intense staining of mannose binding lectin in diabetic animals. Therefore, it goes in favor of the lectin pathway. They also studied and found that there was increased C5a in human renal biopsy tissue, and its concentration is associated with the severity of the diabetic nephropathy. And also, to see the therapeutic side, they gave C5a inhibitor to the mice and found that there was reduced lipid accumulation in the kidney, reduction of the urea and creatinine in the blood, and also there was reduced fibrosis, tubular fibrosis in kidney in the mice. Then they looked for C5b and 9, that is the membrane attack complex, the last portion of the flowchart which I showed earlier. And they found that these were almost equal in the diabetic cases with and without diabetic nephropathy, but the amount is, or the percentage was associated with the severity of the diabetic nephropathy. So what is the point here? The important point is that recent evidences indicates that conventional venoprotective agents used in DKD do not target complement, therefore leaving this web of inflammation stimuli intact. So there is a horizon, large horizon in front of us to manage these DKD patients by targeting the complement therapy. What are those? Let's see here. Two of them are already FDA approved. The C1 inhibitor, which is approved for hereditary angioedema, and this blocks the classical pathway. Second is anti-C5a inhibitor eculizumab, which has been approved for PNH and atypical hemolytic uremic syndrome. There are other drugs like DPP4 inhibitor. It is thought to be act in the lectin pathway. It blocks the those mannose-associated protease, serine proteinase, and blocks the lectin pathway. And it has been hypothesized by a researcher. He gave 131 patients randomly sitagliptin and placebo, and found that there was reduced amount of MBL, and it was thought that C4 is the main culprit in lectin pathway to cause DKD. And what are the other agents in line? These are all under investigations. C3a receptor antagonist and C5a receptor antagonist. One of this is avacopan, which has been prescribed, has been advocated for ANCA-associated vasculitis recently in the KDIGO guideline. So, as I said, there is a large horizon in front of us, so we should focus on the future studies, which should also focus on development of novel pharmacological agents that target the complement pathway to alleviate inflammation, oxidative stress, and kidney fibrosis. So this is all of my today's lecture. I would like to give tribute to this legend today. And not but the least, I also want to share few happy moments of our institute. Okay, this is few pictures of the kidney transplant recipients of our institute. The lower bottom one, Mr. Nurul Amin, who has been transplanted 11 years back, and the above is Mrs. Mahin, who has been transplanted about 15 years back. Subsequently, she got married, and after 11 years after her transplant, she gave birth to this little baby. So these are the motivations that keep all of us going. So thank you very much.
Thank you, madam, for your nice presentation. Now, our third and last topic is diabetes management in diabetic kidney disease. And our third speaker, Dr. Sudhanshu Kumar Saha, working as assistant professor, Bardem General Hospital. Please, I would like to request our third speaker and our last speaker, come on dais.
Bye.
Either view them. कोई नाश नहीं तो
দিতে কেন আরে আপনারটা পাইছো
এটা কাটে
খোলা তো না খোলা তো দেন
আর হবে
চিকনটা হ্যাঁ
আরে জানা হ্যাঁ এটা খুলে দেন Thank you, reporter, for introducing me. Respected chairperson of the session, respected teachers, my dear colleague, senior and junior, welcome you to this honored gathering. I thanks to Gonoshasthaya family, especially Professor Brigadier General Mamun Mustafi sir, for giving me the opportunity. We all know diabetes and diabetic kidney disease is increasing day by day. So, my topic on management of diabetes in diabetic kidney disease. I will talk about introduction, brief idea about diabetic kidney disease, management of diabetes in different stages of CKD, monitoring and target, and lastly conclusion. This is the global scenario of diabetes mellitus. It is a slide from IDF, which shows that diabetes is increasing day by day. In 2017, in Southeast Asia, our diabetic population were 82 million, and it will increase to 51 million by the year of 2045. That is 84% population will be increased. This is alarming. We all know diabetes had some micro and macrovascular complication. Kidney involvement is one of the microvascular complication. This is the data from US state which shows that diabetes is the leading cause of ESRD. Other microvascular complication of diabetes includes cerebral vascular disease, cardiovascular disease, diabetic foot problem, and diabetic eye disease. Now, what is DKD? Diabetic kidney disease is a clinical diagnosis based upon presence of albuminuria, decreased estimated GFR, or both in diabetes. Now, how to screen and when to screen? In type 1, it should be started 5 years after diagnosis. In type 2, at diagnosis. Screening marker 2, spot urine for ACR, preferably morning specimen, and eGFR estimation for serum creatinine. What defines CKD? CKD is defined by persistent urinary abnormality, that is ACR more than or equal to 30 milligram per gram, and or eGFR less than 60 ml per minute, and or evidence of kidney damage. This is well-known slide. All of we are known to this, and in this slide CKD is categorized according to albuminuria and GFR. My topic of presentation today is management of diabetes mellitus in CKD. I use the GFR according to management. Now, general management. All patients with diabetes should participate in the comprehensive diabetes self-management program. That is, it includes diet and nutrition, physical activity, and optimizing glycemic control. For obese or overweight, patients should reduce calorie intake and increase physical activity to achieve weight loss. This is food pyramid in a patient with diabetes and CKD. A patient with diabetes and CKD can consume adequate balanced diet which includes carbohydrate that is rich in whole grain, fiber, fruit, and vegetable, and as well as increased amount of poly and monounsaturated fat. But reduced amount includes refined carbohydrate, saturated fat, and sodium intake should be less than 2 grams per day. Regarding exercise, avoid sedentary behavior to undertake moderate intensity of physical activity for a cumulative duration of 150 minutes per week, or to a level of comfortable with their cardiovascular and physical tolerance. Now, treatment. Treatment include oral agent, non-insulin injectable agent, and insulin. Now, glycemic treatment for early CKD, that is eGFR above 30. Above 30, type 1 diabetes mellitus. Treatment is only insulin and insulin. All insulin are available in our country, but during management, the dose should be reduced in CKD patient. As CKD progresses, dose should be reduced. That is, when GFR above 50, no dose reduction required. But when GFR 20 to 50, around 25%, when GFR less than 10, around 50% dose reduction is required. Now, oral treatment in patients with type 2 diabetes mellitus and CKD with eGFR above 30. Treatment choice is combination of metformin and an SGLT2 inhibitors. Second line, GLP-1 receptor agonist. If with this drug, glycemic status is not controlled, then add other drug. But this should be depends upon patient preference, cost, GFR, and comorbidity. This slide shows how to start metformin and how to monitor when patient on metformin. Metformin can be started when eGFR above 30. 30 or more. Dose. In a patient with CKD, when GFR 30 to 44 and some patient with a GFR 45 to 59, dose is 1 gram. When GFR above 60, dose is 2 to 2.5 gram per day. And two things should be monitored when patient of diabetes with CKD on metformin. First, GFR, and second is vitamin B12 vessel. Regarding GFR, when GFR 30 to 59, GFR should be estimated every 3 to 6 months, and above 60, GFR estimated yearly. And when patient on metformin for more than 4 years, then vitamin B12 vessel should be done. Regarding SGLT2 inhibitor, it should be started when GFR 20 or above. The importance of this drug are, this is genoprotective and cardioprotective medication. This is the simple guide how to start SGLT2 inhibitor in patient with type 2 diabetes mellitus and CKD. Patient selection is important. First, here also GFR, it should be above 20, and proteinuria, that is ACR more than 200 milligram per gram, and potential contraindicate are genital infection, foot ulcer, diabetic ketoacidosis, and patient on immunosuppression. Before starting SGLT2 inhibitor, two things should be kept in mind. That is volume status of the patient, and patient may develop hypoglycemia if SGLT2 inhibitor started along with insulin or other sulfonamide ureas. Now, regarding GLP-1 receptor agonist, it is the second line choice drug of medication. The importance of this drug are cardiovascular risk reduction drug, and it is also drug of choice in patients with overweight and obese. Regarding DPP-4 inhibitor, this drug had no cardiovascular benefit, and selected DPP-4 inhibitor can be used according to GFR. Now, glycemic treatment with advanced CKD, that is, patients who are stage 4 and 5 but not on dialysis. Stage 4, in this stage, metformin is contraindicated. SGLT inhibitor can be continued if tolerated, but in this population, GLP-1 receptor agonist is good choice because these patients are more cardiovascular risk patients. And insulin and short-acting sulfonylurea are often necessary when medications are contraindicated, not tolerated, unavailable, or insufficient. Now, CKD stage 5, not on dialysis. Here, also, oral drug is choice. Oral drug is choice like sulfonylurea, but who had inactive metabolites and relatively lower risk of hypoglycemia. That is, glipizide, glimepiride, and gliclazide are choice in this stage. Other drug can be used like ripaglinide, linagliptin, and cautious use of GLP-1 receptor agonist. Now, treatment of patient on renal replacement therapy. First, hemodialysis patient. In this patient, insulin is choice, but dose should be reduced around 50%. Other drug can be used like sulfonylurea and linagliptin, and few data regarding use of GLP-1 receptor agonist. Patient on peritoneal dialysis. For patient on peritoneal dialysis who had diabetic control with glycemic medication should be continued the treatment. For new development of diabetes, oral drug is choice. If glycemic target is not achieved, then add insulin. Now, glycemic treatment in a patient with kidney transplant recipient. In this stage, also metformin is a good choice, but SGLT2 inhibitor is usually avoided, and insulin and other agents can be used according to eGFR. Now, this is the comprehensive care in diabetes and CKD. What is comprehensive care? Treatment of diabetes in CKD patient, not only control of sugar, but also control of cardiovascular risks and deter the progression of CKD. For this, we start anti-diabetic drug along with, if proteinuria persists, then add RAS blockade, and maximum dose if tolerated. If still proteinuria persists, then then use newly invented drug, that is non-steroidal mineralocorticoid antagonist, that is finerenone. And for atherosclerotic cardiovascular disease, use statin and antiplatelet. The aim is to reduce the cardiovascular risks and also retard the progression of CKD. And this should be assessed every 3 to 6 months. And this is the comprehensive pyramid in patient with diabetes and CKD. In the base, diet and exercise. Then use anti-diabetic medication along with statin and RAS blockade. For cardiovascular protection, use GLP-1 receptor, melanocortin receptor antagonist, and also antiplatelet. For further protection, tight control of lipid, tight control of glucose, and also tight control of blood pressure. Aim to prevent the CKD progression and also retard the and cardiovascular risk reduction. This is the summarization of anti-diabetic medication in diabetes mellitus and CKD. Among the patients had comorbidity. Metformin is weight neutralizing drug. Importantly, metformin is weight neutralizing, not weight losing drug. Weight losing drugs are SGLT2 inhibitor and GLP-1 receptor agonist. For cardiovascular benefit, SGLT2 inhibitor and GLP-1 agonist. For heart failure, SGLT2 inhibitor. Insulin and sulfonylurea, all we know, it is potent anti-diabetic medication, but this drug had no effect on CKD progression or atherosclerotic cardiovascular disease. This is the dose adjustment of anti-diabetic medication according to the stage of CKD. Metformin is contraindicated below 30. Insulin can be used in any stage, but as CKD progresses, dose should be reduced. SGLT2 inhibitor, it should be used when GFR above 20 or more. And some GLP-1 agonist can be used even in patient on maintenance dialysis, like doraglutide, semaglutide, and liraglutide. Regarding DPP-4 inhibitor, linagliptin is safe and it can be used in every stage. Regarding sulfonylureas, it should be used cautiously and avoid hypoglycemia. Now, glycemic monitoring in patient with diabetes and CKD. 3 tools: sugar profile, HbA1c, and CGM. Of this, HbA1c is commonly used. An stable diabetic patient, it should be done every 6-month interval. But when patient develop unstable diabetes and frequent change of medication, it should be measured every 3 months. What is the target? Target of HbA1c in patient with diabetes and CKD less than 6.5 to less than 8%. That is, in early CKD and less comorbid condition, target is tight glycemic control, that is less than 6.5. When patient is advanced CKD or patient on maintenance hemodialysis, target is less than 8%. In a summary, target of management: HbA1c target less than 6.5 to less than 8%, BP target when proteinuria more than 1 gram, then BP target is less than 125 to 75, and proteinuria less than 1 gram, 130 to 80. For LDL target less than 100, preferably less than 70, and BMI 18.5 to 22.9. Now, what are the challenges to management of diabetes in CKD? We all know the HbA1c is a good marker for monitoring glycemic status, but HbA1c may be unreliable because of eudaemia in advanced CKD. Like dextrose in peritoneal fluid can interfere with diabetes management. Metabolism of oral drug is disturbed in CKD patient. Change in dietary intake and exercise is typical of CKD. Change in insulin resistance and metabolism of insulin in advanced CKD. So, Mr. Chairperson, my take-home message: management of diabetes, treat as a whole. Target: control diabetes, control blood pressure, reduce CV risks, retard CKD progression. This is my references. Thanks, everyone.
Now, I would like to, hello. Now, I would like to request our 2 speakers, please come on dais to receive your crest. First speaker, Dr. A.S.M. Inamul Korin, sir, and second speaker, Dr. Isanul Korin. Yes, and second speaker, Dr. Sudhanshu Kumar Saha. Please come on dais. Sir, yes, sir. I'd like to request our honorable chairperson to conclude the session and give his comments, please. And I also like to thanks for inviting me in such prestigious session and to moderate the session. Thank you, sir, and also thanks to Dr. Mashura Javin. Thank you, sir.
In our today's session, this is our first session on diabetes mellitus, and we have enjoyed 3 excellent papers from our 3 excellent nephrologists of our country. And first presentation from Isanul Karim sir, and that covers huge part of our diabetic patients burden. That includes diabetic nephropathy with refractory nephrotic syndrome as well as superimposed GN as well. And he presented a very nice case as well at the end of his session. I must congratulate him. And second one from Dr. Tabassum Samad, that was an excellent presentation which show something very new to us. And I think we have to rethink again and again to treat our diabetic nephropathy patients. And in coming days, there will be some novel therapy in diabetic nephropathy patients as well. And last but not the least, from Dr. Sudhanshu, she delivered excellent and comprehensive talk on management of diabetes as a whole. Thank you all 3 speakers. Thank you all. Thank you, our co-chairperson, sir, and I want to hand over microphone to chairperson, Professor Brigadier General Retired Mohammad Mustafi, sir. Thank you.
বিসমিল্লাহির রহমানির রহিম, শোনা যাচ্ছে আমাকে? Assalamu alaikum. In fact, we had a very mighty presentations this evening. The last presentation, in fact, summarized the
how we should manage a patient with some kidney disease, the management of diabetes in this case patients. And he has described the stages, the drugs, and the monitoring systems also. Hats off, Dr. Sudhanshu, you presented it very nicely. The second speaker, definitely, as my co-chair said, it was an excellent eye-opening gesture to the society. We have not thought about the complements in diabetes, and she has opened the chapter of complements in the field of nephrology. We have lot of things to discuss, and inshallah, as the days progresses, our society and all the community will come up with the matters of complements in diabetic kidney disease. The nephrotic syndrome in diabetes mellitus is definitely a great concern to all the nephrologists, whether it should be a diabetic origin or it should be a non-diabetic origin with the diabetes. And Dr. S. Anul Kurim has presented it so smoothly that everybody possibly realized that things has to be divided. We have to exclude first whether there is any non-diabetic kidney disease or not, and when the biopsy should be done, and what are the drugs and what are the monitoring that we should do. Just one simple thing I just want to add. While I was going through the literature, I found one interesting observations and study. As you all know that we use steroid in case of almost all nephrotic syndrome. So, but in case of diabetes, we can't use these drugs as routine in unlike other conditions. Then here, some researchers found an interesting observations. They had used ACTH patch in case of nephrotic syndrome related to diabetic mellitus, which is not related to any other conditions. And they have found very interesting results that almost 50% patients had remission, complete remission of the diabetic proteinuria. So that is a very eye-opening study that I found in the literature. So these things also I just want to share with you. I am very thankful to all the my chair and my rapporteur, moderator. It has been an excellent session because of the contribution of them. I just want to hand over the crest to Dr. Moksuda Moni, as she has managed this session very nicely.
In fact, the inauguration session is going to be start very soon. Our chief guest, Professor Harun, he was himself sick, but in spite of that, he is on the way because of the heavy traffic today. It has been delayed, but we are expecting in within few moments. And I am very sorry to say that our special guest, Professor Nijamuddin, is also sick. He remained admitted in the hospital just few days back. Our president-elect of the Renal Association is possibly not coming today. So we are going to start our sessions right at this moment. Thank you, ladies and gentlemen.
one for doctors, which has already ended, and another for the staff. All the staffs, please collect your raffle draw coupon. কিছুক্ষণের মধ্যে আমাদের ইনঅগ্রাল সেরিমনি শুরু হবে, তারপরে আমাদের স্টাফদের র্যাফল ড্র, তারপরে আমাদের কালচারাল প্রোগ্রামে যাব আমরা। We are moving to our inaugural ceremony session. Today in our inaugural ceremony, chief guest of today's session is Dr. Haruna Rashid sir. He is a professor of the Department of Nephrology and senior consultant of Kidney Foundation Hospital and Research Institute. He is also founder and president of Kidney Foundation Bangladesh. He'll be with us very soon. Our special guest of today's session, Dr. Mohammad Nizamuddin Chowdhury, who is the professor and departmental head of BRB Hospitals Limited, and he is newly elected president of Bangladesh Renal Association. I'm sorry to say, sir could not attend the session due to his sickness, but he has sent back his message and wished good luck for our GK Nephrocon. We have also among us the guest of honor, Dr. Mohammad Babrul Alam sir, who is the professor of the Department of Nephrology, National Institute of Kidney Disease and Urology, and also newly elected Secretary General of Bangladesh Renal Association. Thank you very much, sir. We are very honored with your presence. Now I'd like to request Chairman of the Organizing Committee, Professor Brigadier General Mamun Mustafi sir, and the Chairman of Scientific Committee, Professor Mahbubur Rahman sir, to come to the stage with our respected special guests, guest of honor. Please come to the stage, sir. And also I'd like to request our new director, Brigadier General Dr. Mohsinuddin Ahmed sir, please come to the stage. Now I'd like to request Brigadier General Mohsinuddin sir to give his speech.
Bismillahirrahmanirrahim. Respected chairperson, distinguished guest, and the august gathering in front. On behalf of Gonoshasthaya Dialysis Unit, I welcome you to this scientific session. Very soon we're going to inaugurate the session under the chairpersonship of the Professor Mamun Mustafi, retired Brigadier General. And the chief guest, that is Professor Harun Rashid, you already know, he is on the way and stuck due to traffic jam. The kidney is the vital organ of the body. So when it becomes disease, so life become hell. So it is our doctor's responsibility to maintain or to stop the disease. Cure rate is very less. So continuous study, seminar will give new idea and new looks. As we have come to know today, the complement system is a new idea. So this scientific session certainly throw a new light and give a new hope to the kidney patients. I expect the successful completion of this conference. With that, I come to conclude my speech and waiting for the inauguration. Thank you very much.
Now I'd like to request the chairman of the organizing committee, Professor Brigadier General Mamun Mustafi sir, to give his welcome speech.
একটা বই দিলা না? বিসমিল্লাহির রহমানির রহিম। আমার সামনে উপস্থিত আমার সহকর্মীবৃন্দ, নেফ্রোলজিস্ট অল ওভার দ্য কান্ট্রি যারা আসছেন সকলে, এবং মঞ্চ উপস্থিত প্রিয় মাহবুব ভাই, প্রিয় মহসিন, এবং আজকের অনুষ্ঠানের সম্মানিত অতিথি প্রফেসর বাবরুল আলম, আসসালামু আলাইকুম। বিজয়ের এই মাসে আমি শুরু করছি আমার প্রিয় নেতা বঙ্গবন্ধু শেখ মুজিবুর রহমানের প্রতি শ্রদ্ধা জানাচ্ছি সকল শহীদদের প্রতি, বঙ্গমাতা সহ যারা মারা গেছেন বিভিন্ন কারণে, সকলের আত্মার রুহের মাগফিরাত কামনা করছি। আমাদের এবারের অ্যানুয়াল কনফারেন্সটা একটু ডিফারেন্ট, কারণ বৈশ্বিক মন্দা এবং বৈদেশিক মুদ্রার সাশ্রয়ের জন্য আমরা এইবারের অনুষ্ঠানটা বিদেশি অভ্যাগতদের বাদ দিয়ে আমরা করতে যাচ্ছি। আমি আশা করছি এই বিদেশি আমাদের বিজ্ঞ ব্যক্তিরা না আসলেও ইনশাল্লাহ আমাদের এই অনুষ্ঠান আগের মতোই সুন্দর হবে। আমি গত দুটো কনফারেন্সে সমস্ত নেফ্রোলজির কাছ থেকে, আমার হাসপাতালের সমস্ত সহকর্মী এবং স্টাফদের কাছ থেকে যে সহানুভূতি, যে শুভেচ্ছা এবং সহযোগিতা পেয়েছি, সেটা ভোলার নয়, এবং সে কারণেই গত দুইটা অনুষ্ঠান যেমন সুন্দর হয়েছে, আশা করি ইনশাল্লাহ এবার অনুষ্ঠানও সেরকম সুন্দর হবে। Ladies and gentlemen, it's my pleasure to introduce the newly elected General Secretary of Bangladesh Renal Associations, my younger brother, Professor Babrul Alam, as he is attending this conference as his one of the first to be there as the Secretary General. Ladies and gentlemen, please give a big hand for Professor Babrul Alam. Thanks to Almighty Allah subhanahu wa ta'ala. He has given us the opportunity to host such a wonderful academic environment for the nephrology community of Bangladesh. We tried our best to make the program effective, but I know there will be many things will come up which could have been avoided, which could have been improved. Ladies and gentlemen, please accept it is our home event, and whatever success is there is because of your presence. And I accept all the difficulties that you have incurred in attending this conference as my failure. Gonoshasthaya Kendra is trying hard to provide equitable treatment to the society irrespective of the social status. The journey is long, and we expect your continuous support to this movement, equitable treatment for all the kidney patients throughout the country. This Gonoshasthaya Kendra, through 45 satellite centers and 9 centers in the Rohingya camp, is providing as much as possible better care service to the community. And inshallah, the better days are also there. We will be improving our quality in the days to come. Our endeavor to improve the nephro care and academic activities will remain as before, and inshallah we will have better coordination in the days to come. I welcome you all the participants, speakers and the chairs for a great get together. Thank you very much. Allah Hafiz.
Now I would like to request our today's session guest of honor, Professor Dr. Mohammad Babrul Alam sir, to give his speech.
Honorable Chief Guest, renowned nephrologist, not only in Bangladesh but also Southeast Asia, our pride, founder of National Institute of Kidney Disease and Urology, and also Kidney Foundation, Professor Dr. Haruna Rashid sir. Sir will be within hours, within few minutes. And our special guest, our newly elected president of Bangladesh Renal Association, ex-head of the Department of Nephrology, Dhaka Medical College Hospital, Professor Nijamuddin sir. As you know, sir is very sick today, so sir couldn't attend this session. I wish sir early recovery. And distinguished delegates from different parts of our country, and the honorable members of Bangladesh Renal Association, and of course the organizers of GK Conference 2022, especially Professor Dr. Mamun Mustafi sir. Very good evening. I would like to express my gratitude to Father of the Nation, Bangabandhu Sheikh Mujibur Rahman, and martyrs of the liberation wars, and also the doctors who sacrificed their lives in recent COVID era. I am very much excited to be here as the guest of honor to have a great chance to meet the wonderful colleagues in the field of nephrology. And you know, kidney-related diseases are on the rise all over the globe, especially in developing countries like Bangladesh. Considering this, Gonoshasthaya Kendra is providing quality dialysis service with a very nominal charge to all the needy people of Bangladesh. Not only that, the dialysis center also provides services to its ultra-poor patient at free of cost. The Gonoshasthaya Dialysis Center, the largest of its kind in the country, provides 300 session hemodialysis daily in 4 consecutive sessions. Moreover, our government has taken a huge initiative to set up 50-bed kidney dialysis center in 22 medical college hospitals and 10-bedded center in 44 district hospital at a total estimated cost of over 2.55 billion taka under project. I am now the project director of that dialysis center. In this regard, I would like to pay my special gratitude to Honorable Prime Minister, Mother of Humanity, Sheikh Hasina. A healthy life is the greatest gift for anyone. All of us must strive to make healthy living a way of life. Human endeavor to create a healthy and disease-free world has resulted in advancement in health science. Now is the time to achieve a healthier, safer, and fairer world for all. I am proud to say that Gonoshasthaya Kendra is heading towards this direction. And the International Conference on Nephrology adding another milestone in that direction. I strongly believe this conference will have a positive impact on our patient as well. Our chief guest, Professor Dr. Haruna Rashid sir, founder of National Institute of Kidney Disease and Urology, NICDO, and also founder of Kidney Foundation. Professor Harun sir is just within us. As I am saying, I strongly believe this conference will have a positive impact on our patient as well. Wishing Gonoshasthaya Kendra 3rd Nephrology Conference 2022 a more fruitful, successful than the previous time. Joy Bangla, Joy Bangabandhu.
Today, our chief guest of the inaugural ceremony is among us. Professor Haruna Rashid sir. He is the founder and president of Kidney Foundation Bangladesh. He has enormous contribution in developing the nephrological field of Bangladesh. We are very lucky to have him as a chief guest of today's session. Thank you so much for gracing our session with your presence, sir. Now I'd like to request Professor Harun Rashid sir to give his speech.
I'm sorry for the late arrival of this important seminar. At the same time, I am very happy that I've given the opportunity to take part in this important ceremony of Gonoshasthaya Kendra, which is known everywhere in the world as a healthcare professionals and contribute to the health of the people, common people, particularly the poor and needy of the. It is my pleasure to be here to speak something on the kidney disease, dialysis and kidney transplantation in this country. As everybody knows that about 85 crore people has been suffering from chronic kidney disease throughout the world, and of them 10% is suffering from end-stage kidney failure. The most important causes of chronic kidney disease nowadays, even in Bangladesh today, is chronic glomerulonephritis, second is diabetic nephropathy, and third is hypertension. As you know, that because of this huge number of chronic kidney disease around the world, in South Asian population, the chronic kidney disease is more than 10%. It varies from 16 to 18%. A small survey is done by the ICDDRB along with the Kidney Foundation, Hospital and Research Institute. We have found that today the prevalence of chronic kidney disease has risen from 16% 10 years before. Now it has raises to about 20% in some areas. Although this does not reflect the percentage of chronic kidney disease of the whole country of the Bangladesh. Even then, if these people has been suffering from chronic kidney disease, according to the rough statistics done, it is presuming that disease is still increasing. During the COVID-19, the number of chronic kidney disease has risen up in every part of the world, and as well as it is affected to Bangladesh population, and many of them develop acute kidney injury followed by chronic kidney disease and end-stage kidney failure. If we like to improve the condition of this chronic kidney disease, we have to fight against with all people, with all association, particularly the Bangladesh Renal Association, and also the stakeholders. And we have to think about two things. In one way, the prevention of the chronic kidney disease, and number two, the treatment of chronic kidney disease. If we consider for the prevention of the chronic kidney disease, we have to increase the number of healthcare professionals, particularly the professions who are involved to treat chronic kidney disease. As a result, because of to do this is not very easy, because to do a nephrologist, it takes about 5 years in Bangladesh. So more opportunities should be set up both to the government and the non-government health professionals how to improve the healthcare professional to this country. And number two is that training is the utmost importance to provide the health to all people in every corner of the world. Fortunately, Bangladesh has the health professional which are not doctors, but the primary care professionals, which is about 14,000 to 16,000 according to the government statistics. So if we can start the prevention program with the primary healthcare profession, perhaps we can able to improve the prevention of progression of chronic kidney disease. So side by side, we have to give more stress on to the prevention as well as to the treatment, and to make healthcare profession to add all sides together. If we can do that, perhaps in the next 10 to 15 years, we are able to control the disease. Even then, we have to make the training program, short and long training program, in order to improve the knowledge of which is being seen in everywhere in the world. If we like to keep pace, we have also to give stress of more and more training to our health professionals at all levels, starting from the nurses to the doctors to the technological and to the health engineer. The government is trying very hard to do this at all levels, but we have to work very fast. Otherwise, we will be lag behind to many of these South Asian countries, and also more so in other countries as well. Therefore, let us try our best to see at all levels how to improve the health, the prevention program, the short and long-term training program, and everywhere, so that we can make the country a prestigious country known to all areas of Bangladesh. Allah Hafiz, Joy Bangla, Joy Bangabandhu. Assalamu alaikum.
Thank you very much, sir, for your excellent speech. Now I would like to extend my thanks to the senior professors who has come from afar to make this program a success. Professor Shohiduzzaman Selim, sir, Professor Shanur Alam, sir, from NICDU, who is newly elected Vice President of Bangladesh Renal Association. Professor B.M. Mubashshar Alam, sir, who is the head of the Department of Rangpur Medical College and newly elected Vice President of Bangladesh Renal Association. We have also among us Associate Professor Dr. A.N.M. Ehsanul Karim, sir, who has come from Shohid Mansur Ziaur Rahman Medical College and who is newly elected Organizing Secretary of Rajshahi Division. Thank you so much, sir. We are honored with your presence. We have also our EC committee member, Dr. Saidur Rahman from Dhaka Medical. Now I would like to request the chairman of the scientific committee, Professor Mahbub Rahman, sir, to give his vote of thanks.
Distinguished Chief guest, honorable teachers, professors, and respected audience. So welcome to this beautiful evening. And we had already heard diabetic kidney diseases, and we have a very good session. And we have also at least 12 sessions tomorrow. So these sessions are very interesting, and they cover a lot of emerging kidney diseases, and they are renowned speakers, and I hope, we all hope that we will enjoy tomorrow's presentation, and we invite you all to attend the session and to make this conference a successful one. Thank you.
Now I'd like to request the chairman of the organizing committee to hand over the crest to our guest of honor. Now I'd like to request the chairman to hand over the crest to our chief guest, Professor Harun Rashid sir. Our newly elected Secretary General of Bangladesh Renal Association, on behalf of BRA, receiving the bouquet. Hip hip, hooray! Hip hip.
You should go.
Moving to our raffle draw section for the staffs. For this session, I would like to request Professor Sattar sir and Professor Mohsinuddin Ahmed sir, Brigadier Mohsinuddin sir, to conduct the session.
বিসমিল্লাহিররহমানিররহিম। হ্যাঁ জ্ঞানস্বাস্থ্য কেন্দ্র তৃতীয় নেফ্রোলজি কনফারেন্সে সবাইকে স্বাগত জানাচ্ছি। আসলে আমরা যে অনুষ্ঠানটা এখন করবো, এই অনুষ্ঠানটা সবার পরে হয়। এই এক্সাইটিং অনুষ্ঠানটা র্যাফেল ড্রটা সবার হয়, কেন র্যাফেল ড্র হয়ে গেলে সবাই চলে যায়। আপনি খাওয়া দেন, যা দেন, সব কিন্তু সবাই কিন্তু র্যাফেল ড্রর জন্য, খাওয়া তো সবাই খায় না, র্যাফেল ড্রর জন্য সবাই থাকে। এখন আমি শুধু বিনীতভাবে অনুরোধ করবো, র্যাফেল ড্র শেষ হওয়ার পরে আরও প্রোগ্রাম আছে, আরও ডাক্তারদের অনুষ্ঠান আছে, সবাই মিলে আমরা গান করবো। মুস্তাফি স্যার গান করবে, আপনার স্যারের গান না শুনে যাবেন না প্লিজ। এখানে আমাদের এই নবনির্বাচিত রেনাল অ্যাসোসিয়েশনের সেক্রেটারি সহ প্রেসিডেন্ট স্যার আসতে পারে নাই, স্যারকেও আমি বিনীতভাবে অনুরোধ করবো যে আমাদের অনুষ্ঠানে থাকার জন্য। এখন র্যাফেল ড্র আসলে ঘুটা দিতে হয় না, এই সবাই ফেলেছেন কিনা? সবাই ফেলছে?
আজকে স্টাফদের জন্য র্যাফেল ড্র শুরু হচ্ছে। প্রথমে 20তম, তারপর আস্তে আস্তে কমতে থাকবে, দেখা যাক কার ভাগ্যে আসে। ওকে, আমাদের বাচ্চা নাই তো বেশি এখানে।
আরো যদি ছোট ছোট বাচ্চা থাকে তাদেরকে সামনে নিয়ে আসবে, তাহলে উঠাতে চেষ্টা করবো। যে মনে হয় আমি যদি উঠাই, মনে হচ্ছে যে আমি কারেন্টটা উঠাই ফেলছি। হ্যাঁ বাবা বাবা 20তম স্যার বলছে, 20তম ইয়ে উঠাচ্ছে।
বিশতম পুরস্কারের জন্য নাম্বার এসেছে। প্রথম নাম্বার 3, শেষ নাম্বার 5, মাঝখানেরটার জন্য কে উদ্গ্রীব? মাঝখানেরটা কত হতে পারে? 7 হয় নাই। 1 কে বলল, 3, মাঝখানেটা যে 1 বলছিল সেটাই সঠিক। 315 নাম্বার 315 পাওয়া গেছে। চলে আসেন সামনে। আমাদের ম্যাট্রন পেয়েছেন, অত্যন্ত আনন্দের বিষয়। 20তম পুরস্কার
আমাদের মেট্রনের জন্য একটা তালি।
হ্যাঁ ওকে, তুলো। এবার 19তম, কোনো টেনশনে রাখবো না, তাড়াতাড়ি বলে দিব। 286 ওকে ওকে, অনেক পরিশ্রম করেছে লিটন এবং সে পেয়েছে, ধন্যবাদ। লিটনের জন্য জোরে তালি।
যারা লিটনকে চেনে না, লিটন হলো আমাদের এই হাসপাতালের সিভিল ইঞ্জিনিয়ার ইন চিফ। তো ও সারাদিন পরিশ্রমে ব্যস্ত থাকে, পুরো হাসপাতালে যেখানে যত ঝামেলা আছে সবকিছু লিটনের ঘাড়ে থাকে। লিটন, তোমাকে কনগ্রাচুলেশন।
এখানে ভাঙা গড়া কিন্তু ও লিটনেই করে।
14, তার পরের নাম্বারটা বলে নাই, কে আশা করতেছেন? কত? শুধু 14 তো নয়, আরেকটা নাম্বার আছে 7। ইস, আরেকটু একবারে জানো। 148 148 1481 1482 1483 নাল।
আরেকটা দিলো।
18তম পুরস্কার জন্য চলছে 256 256 2561 2562। কে পাইছে? কে হাত তুলেন, আগে হাত তুলেন। ইয়েস, কুইক কুইক কুইক। 17তম পুরস্কার
মিলেছে।
কুইক করতে হবে। কয়টা গেল? না, 18 গেছে। খুব সুন্দর নাম্বার, প্রথমেও 1 শেষেও 1, মাঝখানে না। ইয়েস, হু ইজ 4? 141 141। ইয়েস, প্লিজ কাম, চলে আসুন, তো দ্রুত চলে আসুন। 141 ভোল্ট, মানে আমাদের ইলেকট্রিশিয়ান উনি পেয়েছেন।
এই কে আমাদের ইলেকট্রিশিয়ান পাইছে, বুঝছেন তো? হ্যাঁ, এই ছবি নেন। কত? 17তম নাকি? 16তম প্রাইজ, 16তম পুরস্কার। বাবা উঠাও একটা উঠাও। লাস্ট
3টা নাম্বারই 1, বলেন কত নাম্বার?
কত? প্রথমটা 2, লাস্টেরটা 2, মাঝখানে 2 2 2 2। কে? হ্যাঁ, চলে আসো, আমরা দেখি, মিলাই দেখি। হ্যাঁ, মিলেছে। ওদিকে বাবা, ওদিকে তাকা রে। 15তম প্রাইজ। এবারে 2, লাস্ট 7, মাঝখানে 207 207 207 207। উনি কিন্তু গতবারও পাইছে, কিন্তু প্রত্যেকবারে পায়। 207, হ্যাঁ মিলেছে। হ্যাঁ, দেন, গুড। আরে মামুন মুস্তাফির জন্য দোয়া করবেন। 14তম প্রাইজ।
লাস্টে আনলাকি 13, ফার্স্ট নাম্বার কত? লাস্টে 13, 13, ফার্স্ট নাম্বার। নাম্বার 213, নাম্বার 213, 2131, 132, 133, ক্যান্সেল। Number 241, number 241, 241, 2411, 2412, 2413, cancel. 382, 382, number 382, 3821, 3822, 3823, cancel. কত ভাগ্য জোড়ে গেল। আগের জনের আগের নাম্বার, নাম্বার 147, 147, yes, please come. নেন 147 আসো। দেখো 147 নাও। 147 এদিকে ঘুরে ঘুরে Number 166, number 166, number 166, 166, 1661, 1662, 1663, cancel. কে কল দাও না কেন? আছে ভাগ্য প্রায় ছুটে গিয়েছিল। ওকে, নেক্সট নাম্বার 14, লাস্টে কত? 14, 4 এর থেকে 1 বাদ দিলে যেটা ওইটা। ইয়েস, 143, 143, ওকে আসো আসো। এবারের ভাগ্যবান 270, 270, কোথায় ঘুমাইছিলেন? হবে হবে হবে। আপনি দেন, ওকে, থ্যাংক ইউ। পরবর্তী নাম্বার 108, আসো, কুইক কুইক কুইক। মুন্ডা হ্যাঁ, না মিলছে। থ্যাংক ইউ। Next lucky 210 0 0 210. Yes, please come. এই অনেক কষ্ট করে রুম ঠিক করতেছিল, পেয়ে গেছে মিঠু। হ্যাঁ ঠিক আছে। Next number, last number 3, first number 1. মাঝখানে 3 রাখকে 9 193 19. Yes, আপনার এটা পাস হয়ে গেছে আগে, আপনার এখানে নাই, এটা সামনে। হ্যাঁ 19 গুড। নাও ধরো। নেক্সট নাম্বার 2 2, তারপরে গোল্লা 220। কে পাইছে? গুড, একদম ঠিক আছে। ভাগ্য যখন আসে, ঠিক আছে। থ্যাংক ইউ। এবার পঞ্চম গিফট 2, মাঝখানে বললাম না, লাস্ট নাম্বার 3। নো নো 283 283। কে? পড়ে দেন না সোজা। হ্যাঁ ওই একটা হইলে হইলো। হ্যাঁ দেখি বাবা। হ্যাঁ ওদিকে ধরো। হ্যাঁ হ্যাঁ গুড। ওকে, থ্যাংক ইউ। যাই হোক, লাস্ট নাম্বার 3, ফার্স্ট নাম্বার 3, মাঝখানেরটা লাকি নাম্বার 7373 373। ওই যে আছে, নাই বললে হবে না, ভালো করে দেখেন। 373 তো ফিফথ প্রাইজ। হ্যাঁ 373। এটা হলো 4 নাম্বার না? লাস্ট নাম্বার, সুন্দর সুন্দর নাম্বার আসতেছে। লাস্ট নাম্বার 1, ফার্স্ট নাম্বার 1, এবং মিডল নাম্বার আগের যেটা ছিল ওইটা। 171 171। আরে আওয়াজ দাও জোরে। এই তো, সাবাস। ওকে, ওদের ঘুরো। হ্যাঁ হ্যাঁ না, আর ডাকেন, এখন ডাকতে গেলে নাম নুম কইতে মনে নাই এখন। খুব সুন্দর। লাস্ট নাম্বার 1, সরি লাস্ট নাম্বার 7, ফার্স্ট নাম্বার 1, মাঝখানের নাম্বার নো। এখানে জিরোর এত প্রবণতা কেন? ইয়েস, ইটস রাইট, 0107। বারবার কিন্তু ভালো বলতেছে। নাও ইয়েস, এখন গুরু গম্ভীর সেকেন্ড প্রাইজ, আস্তে আস্তে বলবো। হ্যাঁ, এবার ফার্স্ট নাম্বার 1, সেকেন্ড নাম্বার 9, লাস্ট নাম্বার ইয়েস 7 কে বলছে। ইয়েস, কাম প্লিজ। আরে এই পুরস্কার দেওয়ার জন্য আমরা প্রফেসর সেলিমকে এখানে আসার জন্য অনুরোধ করছি। নাও তুমি ঘুরো। শিরিন আক্তার পেয়েছে এটা। নাও দ্য ফার্স্ট প্রাইজ, এটা আমি নিয়ে যাব, নাম্বার আর বলবো না। হ্যাঁ,
গোটা হবে লাস্ট প্রাইজ, ফার্স্ট প্রাইজ। নাও একটু উঠাও। হ্যাঁ,
এটাই নাম্বার লেখাই নাই, কি যে করি। তো তারপরে পুরস্কার দেওয়ার জন্য আমরা প্রফেসর বাবরুল আলম সাহেবকে আসার জন্য অনুরোধ করছি। হ্যাঁ,
এই প্রাইজটা দিবে, প্রাইজটা পেয়েছে আমাদের ডায়েটিশিয়ান। স্যার প্লিজ, স্যার সবাইকে করতালি দিন। থ্যাংক ইউ। হ্যাঁ, পুরস্কার বিতরণী আমাদের প্রায় শেষ, এরপরে কালচারাল প্রোগ্রাম।
যারা পান নাই দুঃখের কিছু নাই, টিকিটটা ফেলে দিন,
আগামী বছর হবে ইনশাল্লাহ।